Hello, my name is Imani Fennell, and I will be presenting on intestinal microbial metabolism of phosphatidylcholine and cardiovascular risk. This research was done in the Department of Cellular and Molecular Medicine at the Lerner Research Institute at the Cleveland Clinic in Cleveland, Ohio. Again, this research is presented by me, Imani Fennell, and I am a student in Dr. Chen's microbiology course, fall 2015. So, I would like to go over an overview of how I will be presenting this research paper. First, I will begin with some background information. Then I will talk about the research aim, methods, results, conclusion, and finally, future research in a new direction. So, intestinal or ingested phosphatidylcholine is the major dietary source of total choline, and it is acted on by intestinal lipases to form a variety of metabolic products. Choline-containing nutrients that reach the cecum and large bowel may serve as fuel for intestinal microbiota, producing trimethylamine, also known as TMA. TMA is rapidly further oxidized to trimethylamine N oxide, which is known as TMAO, by hepatic flavin-containing monooxygenases, otherwise known as FMOs. TMAO enhances the accumulation of cholesterol in macrophages, the accumulation of foam cells in artery walls, and atherosclerosis, all factors that are associated with an increased risk of heart attack, stroke, and death. So in this research, we examined the relationship between oral intake of phosphatidylcholine and the involvement of the intestinal microbiota in the formation of TMAO in humans. We also examined the relationship between fasting plasma levels of TMAO and the long-term risk of incident major cardiovascular events. These researchers believe that increased levels of TMAO led to higher risk factors of death, heart attack, and stroke. So in order to do this research, there were two separate studies done. And in the first study, 40 healthy adults were observed that had no chronic illness, no active infections, no antibiotics or probiotics within the past month. These 40 healthy adults underwent a dietary phosphatidylcholine challenge, which included them, each participant had a baseline blood and spot urine samples obtained after an overnight fast, which was 12 hours or more. At baseline, participants were given two large hard-boiled eggs, including yolk, which contained approximately 250 milligrams of total choline each, which were to be eaten within a 10-minute period together with 250 milligrams of deuterium-labeled phosphatidylcholine, otherwise known as D9 phosphatidylcholine, as a tracer contained in a gelatin capsule. 6 of the participants were given antibiotics, metronidazole. They were given 500 milligrams twice daily, plus ciprofloxacin, 500 milligrams once daily for 1 week. And these participants did this for a total of 3 visits. And then serial venous blood sampling was performed at 1, 2, 3, 4, 6, and 8 hours after baseline, along with the 24-hour urine collection. The second study examined the relationship between fasting plasma levels of TMAO and incident major adverse cardiovascular events during 3 years of follow-up in 4,007 patients. And these 4,007 adults were undergoing elective diagnostic cardiac catheterization. These participants had no evidence of an acute coronary syndrome, and fasting blood samples were taken from all participants at time of cardiac catheterization. Now I will discuss the results. This first figure is showing the effects of phosphatidylcholine challenge and the administration of antibiotics on mean levels of trimethylamine N oxide, TMAO, and its D9 isotope log, D9 TMAO. This figure is showing the results of the assays for TMAO in panel A, as well as D9 TMAO in panel B. These results are after the phosphatidylcholine challenge, before and after the administration of the antibiotics, with the intensity of stable isotope dilution assays measured by means of high-performance liquid chromatography. The arrows indicate retention time where authentic isotope labeled TMAO standards elute. Also shown are the plasma levels of TMAO in panel C, as well as the plasma levels of D9 TMAO in panel D at each visit. The plasma levels of TMAO were markedly suppressed after the administration of the two antibiotics and subsequently reappeared after the cessation of the antibiotics. This indicated that the production of TMAO from dietary phosphatidylcholine is dependent on metabolism by the intestinal microbiota. Furthermore, to explain this in further detail, the suppression of intestinal microbiota by the administration of oral broad-spectrum antibiotics for 1 week in 6 of the participants resulted in near complete suppression of detectable TMAO and D9 TMAO after the phosphatidylcholine challenge during visit 2 in both plasma and urine. After the withdrawal of antibiotics and subsequent reappearance of intestinal microbiota over a period of 1 month or longer, the phosphatidylcholine challenge during visit 3 again resulted in readily detectable and time-dependent changes in TMAO and D9 TMAO in plasma and urine. So this table shows the baseline characteristics of the 4,007 participants in the clinical outcome study according to whether they had a major adverse cardiovascular event during 3-year follow-up. The mean age of participants was 63 years, and 2/3 of the participants were men. The prevalence of cardiovascular risk factors were high, and many of the participants had at least single vessel coronary disease. Participants who had major adverse cardiovascular events also had higher baseline levels of TMAO as compared with those who did not have cardiovascular events. Increased levels of TMAO remain significantly associated with an increased risk of death in non-fatal myocardial infarction or stroke. And the p-value is for the comparison between patients who had a major adverse cardiovascular event and those who did not. So in this table, it is showing the risk of a major adverse cardiovascular event at 3 years according to quartile of TMAO level. As compared with participants in the lowest quartile of TMAO levels, those in the highest quartile had a significantly increased risk of an event. So this chart is showing the data for the 4,007 participants in the clinical outcome study, and the p-value is for all comparisons. And as said before, those in the highest quartile, which is quartile 4, at the 3-year follow-up showed the highest prevalence of myocardial infarction, which is heart attack, stroke, and death. In conclusion, we have shown that intestinal microbes participate in phosphatidylcholine metabolism to form circulating and urinary TMAO. We also established a correlation between high plasma levels of TMAO and an increased risk of incident major adverse cardiovascular events that is independent of traditional risk factors, even in low-risk cohorts. So this research left us with some remaining questions and possible future research directions. Although an association between infectious organisms and atherosclerosis has previously been postulated, Excuse me. Although an association between infectious organisms and atherosclerosis has previously been postulated, studies looking at the role of antimicrobial therapy in preventing disease progression have been disappointing. Even if an antibiotic initially suppressed TMAO levels, the durability of that effect with long-term use remains unknown. So, for possible further research, instead of using an antimicrobial therapy that is based largely on targeting postulated organisms, we can modulate the composition of intestinal microbiota or their metabolites. The findings in this research point to the possibility that plasma TMAO levels may identify a pathway within intestinal microbiota amenable to therapeutic modulation. Further studies are warranted to establish whether antimicrobial therapies can significantly reduce cardiovascular risk. That is the end of my presentation. Thank you.